We have a very interesting patient here with multi-level atherosclerosis. He's a claudicant now, very short distance, and his ABI index is 0.36 now, so he's pretty critical. 2 years ago, almost the same procedure was performed successfully. He has a chronic total occlusion of the superficial femoral artery, almost a flush occlusion. And our colleagues managed to perform the successful recanalization, not successful from antegrade, so they had to puncture the distal SFA and go retrograde because they were unable to go into true lumen from above. And this reconstruction was working for a year and a half, and since 6 months he started experiencing this claudication again. So we're now going contralateral from right to left, and let's see the pictures.
So probably during the last intervention, because we show the figures, actually the colleagues have done a great job there. But it seems that despite the use of DCB, it was a suboptimal recanalization, and probably we have some kinds of recoil. There is some calcification, let's say moderate calcification. Here is the occluded SFA. There is very small stump there. Let's go to the next picture. And then, no, go to the angio, please. Go back. Go back. Here
could
you are.
Could you explain for the audience, sorry, could you explain for the audience how do you engage within the stamp and what kind of materials do you use in this case?
With stent. We don't have any stent here.
There is no stent.
So there is no
no,
stent
I mean
here.
the stamp, the nose,
okay,
the stamp.
Sorry, I didn't hear it. Let's see, first of all, the outflow. We have a patent P1, distal SFA P1 segment. There is a good trifurcation there. We know it also from the previous diagnostic angiography. And now the idea was to try to go from the stem. Let's go back now to the previous. So the stem here, you see, it is difficult. So what we are doing in this case is either you can use a Berenstein catheter or you can use a catheter like a rim one to cut it in such an angle that it is more or less a Berenstein catheter in order to direct the catheter and to have enough pushability. We need more, let's say, we need catheters that are relatively stiff. I like always the Cordis catheter in this indication. And by this way, we have used the Berenstein catheter and then command the 18 wire to penetrate the proximal stump. Let's see how it was done. Next, please.
For our colleagues, I will tell that it's possible also to use the internal mammary catheter because,
yes.
Not everywhere Berenstein is on the shelf, but internal mammary play the same role in order to engage the proximal part of the cup.
Yes,
and of course, angulation, ipsilateral angulation of the X-ray machine is necessary in order to see the ostium of the profunda and the stamp itself.
Exactly. So we are almost 24 LAO now, left oblique view, in order to be very sure where we're getting inside. It was almost 100% predictable that, we lost this. It was almost 100% predictable. I think we were outside.
Theo, I have a question for you. You stick with the 018 platform for SFA?
Yes, I'm trying to avoid 035 for the SFA. I'm starting using more and more 018 wires. Now we lost the wire here, but I try to get it like this. Probably yes, but let me try.
Do you use a support catheter when you engage, or you use a balloon catheter for support?
I'm using a support catheter. This is the Cornelian.
Cornelian, okay.
Okay. So we were able now to the small channel. You see here, I have the wire, the D18. It is only the proximal tip that it is outside the Cornelian. and I'm just pushing the Cornelia, give me a dry gauge.
Без суха марла.
Theo, what
And
wire?
then I'm just pushing further down. Here you are pretty sure that you are in
Theo,
something
you're in a
position.
good position. What would you prefer if this wire didn't work? What would you prefer? Would you step up? Which kind of wire?
No. No, I
For
will go for an
example,
Astato. Or I will go for an
Astato,
Astato.
directly Astato. Okay.
Yes. I need you know, a wire that has enough power to penetrate the cap. Now I'm just going a little bit. I'm rotating the catheters just to go.
Another
this
good
difficult
CTO wire
case.
is the Connect 250.
Yeah. Sometimes
Here is
I have to stick the back of the Therum. I don't recommend it.
Yeah.
I do not recommend it, but sometimes it is so calcified. You cannot work with all 35 wires. You cannot work with the conger wire. You cannot with the hydrophilic sieve body. And then even Astato doesn't work. So then just to stick.
Like they
just
say,
to have a, just
this
to have,
is the penetrating
Yeah.
device of the pore.
yeah.
Totally right.
But the go-back catheter has such option.
Go
With the
back
needle.
catheter is the indicated one, yeah. In fact,
Absolutely.
that is indicated both for penetrating the cap and also to go back. It's really very, very good device. It's Israeli, I think. It's, yeah.
If you penetrate the cap, then you have done the procedure 30%.
Yeah.
So it's
It's
important.
important.
So try to push it.
Theo, do you think
Yes.
you're intraluminally or subimplantially?
No, it's-
Of course not.
Subintimally.
Of course not.
Okay.
Go back and try to penetrate. Go further.
Do you use all 35 wires in SFA intervention?
All?
All 35 wires.
Okay, very good.
Yes, yes. In 90% of the cases,
Yeah,
we
yeah.
are coursing with Super J, 035. And I like very much the Gladius,
Yeah.
Gladius peripheral Gladius, and also the peripheral Gaia.
Yeah.
The PV Gaia is really very good one.
Keep the wire.
With,
in place.
with Gaia peripheral, you are most of the time managed to be intraplaque rather than go outside the vessel.
Exactly.
And we have also the Halbert 12 gram. It's also very useful.
Yeah.
It's also an Asahi wire. So you can also manage to go with a long distance in intraplaque.
No, absolutely. Theo, it's probably...
So now we are.
we are
Yes,
discussing about go-back maneuvers. And I don't know what you think, but for example, the go-back catheter is one of the options. And
Yes, it is the best option if you want to avoid an retrograde puncture. Here,
Yes.
however, we will try a little bit more just to be sure that we have no possibility to go inside.
yeah, we can appreciate the huge calcification there.
Yes, and it
It's
is not only the calcification,
Not
it is
very
also
easy
the stepping
to
of
go
course.
back in such a calcium.
Do you use the go-back catheter a lot?
Yes, yes.
Yeah.
Yeah.
I think it would be good here because you are
Absolutely.
now on the vessel surface.
And because they crossed, always they have some channel.
Yeah.
And the 4 French go back, it's very suitable in this situation.
Because
Okay, we're pretty
the
close.
wire is
Uh,
totally
Still,
it's totally on the vessel architecture. So this catheter could really work here.
Sorry, guys.
Or you have to do
So now we have to work a little bit more. Do you have a command?
or he has to do a distal SFA or a peroneal puncture retrogradely because this is all calcified. I hope it's not going to go to a reverse card procedure or a card procedure because it's very calcified there. And of course, not losing the landing zone is also important. You cannot go beyond the landing zone, dissecting all up the vessel. So I think we should keep up above the landing zone.
Theo, are you still with the command 018?
Yes,
Yes. Okay.
I'm trying to be always cost effective because otherwise we have so many devices, but we have always to think a little bit on costs in these cases. I don't like
You are probably born in Bulgaria.
But
So
look
can-
at the
can you
distal
show me
cup,
the previous angio?
it's type 4. It
Can
will
you
be
show
easy
me?
for
So,
distal puncture.
if you see here, I will also explain you
Look at
later
that,
on
yes.
on my presentation. You see a concave distal
Yeah.
cup. So it will be nice if we can go on the left side of the vessel. We have higher probability to get inside the true lumen. But
Yeah.
I will try to do this. However, I'm not promising that we will achieve this because the wire has its own god.
But
You-
you will succeed in the end. I'm sure.
Yeah.
You probably can take
here it's
at least new command wire without
Yeah, I will
changing
take now.
the type,
I
but
will take now.
to
Yeah, tell me.
change
Sorry.
the wire.
Give me now the command.
Yeah, because the tip is already
Yeah, it's already
damaged.
done, so it doesn't serve for anything.
So give me a little bit
It's
of contrast.
absolutely unpredictable now with this wire.
Yeah.
So
I
let's do
admire
the
what you are
first
doing
angio.
just with one wire. It's excellent.
Okay, great.
Not bad. You have
Give me
1
I will try
centimeter.
now for a 014 wire. It has a higher probability to get inside any kind of dissection. Otherwise, we're going to use the re-entry catheter here.
Again,
Yeah.
command 014.
Yes, command 14. You see, I'm really fixed on these two wires, command 14 and
It seems so.
018. I do not have any conflicts of interest, but I have a really good experience with both of them.
Yeah, it's obvious also.
Let's see. Here you are. Okay. Give me a torque.
Everybody has his favorite wires.
Yeah, yeah,
V18,
Yeah,
command,
but this is
advantage.
good.
Yes.
Yeah.
Yeah.
Because in skillful hands, different wires are working perfectly.
Yeah,
So it depends on the familiarity.
yeah.
Absolutely.
So I'm trying to rotate a little bit. Do you have a new command?
Yeah, exactly.
Yes, we can. Yeah, give me one. Okay. So.
It's shifting laterally.
So
again.
here probably we are subintimally, but we will see. Yeah, just a moment.
I think you need a retrograde puncture, but
I think it's
still
subintimally.
superintimally.
Keep the wire. Okay, stay there.
Yeah.
So I am now below the.
Oh, you're in.
Oh,
Oh,
great.
you're in. Great.
You're in.
Let's see.
Very good.
Yeah.
Okay.
You
So now
convinced.
we're gonna start. Oh, no, let's do something else.
So you can do everything with command. Command 014, command 018. You
Yeah,
can do
command
everything
014.
with
Abbott
with these
will
two
love me.
wires.
Today, let's go to change for an 018 just to have more. Okay, here you are.
Yeah,
Theo, is this the Cornelian?
you are done.
This is the Carnelian, yeah. You
How
see
is it
how
past
it's
the
doing a great
occlusion?
job actually, but you have to work with Cornelian. You have to work two people because when you are pressing or you are pushing, let's say, the wire, you are always having the Cornelian coming back. So someone is pushing and the other one is keeping the Cornelian at place. So it looks good.
Excellent.
Yeah, good.
Yes.
Good
Always
confirmation.
even if you are pretty sure that you are inside, always check where you are.
And what is your strategy now?
Now
With,
I will start with a 4mm balloon catheter. I will open it, and then we will see how it looks like.
You change now for a new command. Is it right? Command 014.
Now we are changing for a new command 8. The old one.
the old one.
So still we are cost effective.
We've already crossed.
Yeah, so we don't need to have a new one. So I will go down that just to be sure. Oh, here is the. Here is.
Yeah. From the
This is the biggest
administration of
mistake.
Tokuda, they will appreciate that.
Okay, let's keep it here. Okay. So let's keep it
The
here
industry
and
will not like you, just with two wires. With such a complicated SFA.
So the loop is my favorite loop because here you cannot really have any injury.
Damage, anything, yeah.
Yeah. So, and then give me the balloon. You can do it, sure. Okay. Let's lift. Okay, perfect. We have the wire in place. I have the wire now.
Okay,
And now
so
let's start to see what happens here.
can you hold the wire?
Yes, I have it.
Okay.
And give us the balloon. 4, 100, not 6, 4 millimeter. Yeah, this one. Yes, good.
120.
So the point is, we had a previous, let's say, some minimal recanalization, a previous use of DCB, but still, again, a reocclusion. Even if we have a good angiographic result, my question to you, would you stent it in any case or not?
I think it's very difficult here going without a stent because you have a long calcification, what we will see after ballooning. And is there a reason you chose a 4 millimeter balloon because the SFA is always greater than 4, first, and second, you are above the Hunter channel. So I think beginning with a 5 millimeter balloon would be not a bad option. But is there a reason you chose a 4? In the popliteal region, you are right.
Yes.
Okay, you can begin with a 4. It's also good.
I want to be very smooth always with the balloon. So I believe on vessel prep, I believe on DCBs, but at the same time, I believe that we have to be very gentle with such as CTOs in order to reduce the length of stenting. There is a big discussion. Sorry.
Yeah, thank you, Theo. Sorry, you did in fact the most challenging part of the job on an excellent way. And because since a long time it's a lunchtime, if you allow me, we are going to have some break for a short lunch, and after that you are going to show us your stepwise approach and what you have done. Do you agree?
Okay. Keep a plate for us, just because we are hungry as well, and then go, please.
Okay. Yeah. We believe in you.
Yeah, thank you. Bye. See you later.
Thank you. Let's go.
When you left us, we were at the point where we had a guide wire into the popliteal artery. Then we changed the guide wire for V18 because it offered more support. And then we started the inflation of 2 long 5 millimeter balloons, plain old balloons, no packet Excel.
Okay.
Then we performed dilatation with 6 millimeter by 200 drug-eluting balloon, followed by another 6 by 100 drug-eluting balloon. So we treated the whole SFA with packet Excel. We were sure at the very beginning of the case that we need to use stents because the results after the balloon was very, let's say, not satisfying enough. So we decided to put 2 self-expandable stents, and we covered the whole area. The proximal stents ends at the very beginning of the SFA, not covering the profunda. It's clear by this run.
Yeah.
Can we see the next one?
Very
Maybe
precise. Very precise
Yes.
implantation. Okay.
I must say
Congratulations. Really very good result. What kind of drug-eluting balloon did you use? Quite long one?
It was 6 by 200. It's a Biotronic.
Biotronic.
Vassil.
Yeah, great. Great, really
I must say
very good.
the stand was positioned really precisely, and that was very important.
It's a 6 millimeter stent?
Yes, it's 6 millimeter.
6 millimeter. Yeah, there is some residual stenosis, but it's not dramatic. So,
Well, believe me, we performed post-dilatation several times by 12 atmospheres, and this was all we could achieve. And I think it's reasonable result. Let's see the next one.
Absolutely. Without a shock wave, yeah, it's a quite good result.
Yes, the TBO vessels are patent. We have no signs of distal.
Could you show us? Could you show us below the knee result?
Yes, my colleagues will change this in a second. Can we? Okay, perfect.
Fantastic popliteal, very good.
And you see the
this is, in fact, here is the exit. Our colleagues, could you go back? The exit of the dissection is very well seen. You see the distal, and it's very well covered by the new stent. So definitely this is a good result. And let's see the below the knee result as well.
This is as far as we can go due to technical reasons, but by the speed the contrast is cleaning, we can say that there's
Yeah, most
no...
probably, yeah,
Yes,
the outflow is good one. Could you tell us what is the plan? How are you going to close the access, right femoral access site? Manual compression or a closure
Well,
device?
here we are huge fans of manual compression, so
Okay.
that's the way to go.
Yeah, okay, you probably have enough residents to compress, so it's, yeah, it's a good option.
Lots of fellows.
Good point.
Lots of fellows.
Good point.
Okay, thank you. Thank you very much.
You're
Great
welcome.
case, very instructive. Thank you.
Good point. If you're working alone, so if you have to do the whole thing by yourself, then you jump up to closing devices. But if you have residents,
Yeah, it's workforce.
yeah, yeah.
Okay, good. We can continue.